మనం ప్రొలాక్టిన్ గురించి మాట్లాడుతున్నాం. ఓకే, prolactin. Fine. ఓకే, సో ఇప్పుడు మనం యాంటీరియర్ పిట్యూటరీ గ్లాండ్లోని గ్రోత్ హార్మోన్ మాట్లాడాం. నౌ వీఆర్ టాకింగ్ అబౌట్ prolactin. ఓకే, సో దీస్ బోత్ growth hormone and prolactin are acidophilic hormones. Okay. Therefore, it is homologous to prolactin is homologous to growth hormone, and it is released from lactotrophs of anterior pituitary. We all know this. Okay. So now let us talk about the functions of the prolactin. So this is the prolactin. Now what are the functions of prolactin? One, you know already that breastfeeding. Okay, that is breast milk production. It helps in breast milk production. Next, it also inhibits GnRH, okay, gonadotropin releasing hormone. Therefore, there is no ovulation in females and there is no spermatogenesis. There is no spermatogenesis in males. Okay. Now, prolactin is under the control of 3 hormones. That is dopamine, thyroid releasing hormone, and estrogen. Dopamine inhibits the prolactin, whereas TRH and estrogen stimulates the prolactin. Okay. So, in which cases TRH is increased? Primary or secondary hypothyroidism. Okay. In these cases, there is because of negative feedback, there is increase in thyroid releasing hormone. Whereas in case of pregnancy, obviously there is increase in estrogen. Okay. So in pregnancy also, because of increased estrogen, as it stimulates the prolactin, it leads to galactorrhea. And in some patients with hypothyroidism, they also present with the galactorrhea because of increased production of TRH that stimulates the prolactin. Now coming to the dopamine. So in which cases you will see inhibition of dopamine. Okay. For example, dopamine antagonists like antipsychotics given in psychiatric patients. Okay, they will inhibit dopamine. That's why there is no inhibitory action on the prolactin, and prolactin levels increases, they present with galactorrhea. And some drugs like that, any chest wall injury stimulates ANS that causes inhibition of the dopamine. Next, mother. In mothers, when the mother sees sight or cry of baby, causes inhibition of dopamine. Therefore, dopamine is inhibited and prolactin is increased. Okay. And one more thing is nipple stimulation. When the baby sucks the mother's breast or mother's nipple, on stimulation of nipple, there is inhibition of dopamine that leads to increase in the prolactin levels. Nipple stimulation. Okay, fine. So prolactin is under the control of 3 hormones: dopamine, TRH, and estrogen. Prolactin stimulates breast milk production and it inhibits GnRH that leads to anovulation and no spermatogenesis. Okay. Now you got to know what are the mechanisms, what are the functions of prolactin, and under which control it is present. Okay. Now we'll talk some pathologies related to the prolactin. Okay. The main pathology, one and only one pathology that we will discuss about the prolactin is prolactinoma. Okay. Actually, in the pituitary tumors or pituitary adenomas, there are two types, functional and non-functional pituitary tumors. In functional tumors, most common is prolactinoma. So, what is the prolactinoma? It is the pituitary adenoma. Okay, most common functional pituitary adenoma. So, the patient with prolactinoma, how she will present? A patient, for example, a female patient, okay, presented to us with amenorrhea, that is secondary amenorrhea, and galactorrhea and infertility, or a male presenting to us with impotence and galactorrhea. Okay, if prolactinoma in females present like this, in males they will present like this. Okay, but immediately you should not confirm it as prolactinoma. So first we should go for differential diagnosis. So secondary amenorrhea she is telling. So if she is reproductive female, she might be pregnant also. What are the differential diagnosis for these clinical features? One, she might be pregnant, and all these features are relating to increased prolactin levels, right? So in which cases again you will see increased prolactin levels? Yes, hypothyroidism, primary or secondary hypothyroidism. Yes, and in which cases you will see the patient who is using antipsychotics, in history of antipsychotics. So, immediately after seeing these clinical features, first you should rule out pregnancy by checking urine HCG levels. And you should rule out primary and secondary hypothyroidism by checking TSH and T3, T4 levels. And by knowing the history of any psychiatric disease who is under medications. Okay, in all these conditions we will see the same features. So after ruling out all this, there is no increase in HCG levels, normal T3 T4 levels, and no psychiatric problems and no medications she is taking. Now what you will do? Now oh fine. Now what you will do? Yes, you know what you are going to do. So you ruled out all three differential diagnoses. Now you're feeling like most probably it is prolactinoma. So what you will do? Go for serum prolactin levels. Check serum prolactin levels. If it is more than 200 microgram per liter, it is suggestive of prolactinoma. What are the normal prolactin levels, normal serum prolactin levels? 5 to 20 microgram per liter. And you should go for MRI to see the size of the pituitary adenoma. On doing MRI, you will get to know whether it is microadenoma or macroadenoma. Microadenoma means less than 1 centimeter, macro means more than 1 centimeter. If it is in females, most commonly females will have microadenoma, whereas macroadenoma is common in both males and females. Okay. Now, finally, you got to know that she is having prolactinoma and it is pituitary adenoma. So, what treatment you are going to give to her? What the treatment? Should decrease the prolactin levels by giving dopamine agonists like cabergoline and bromocriptine. Okay, bromocriptine. Bromocryptine. All both these are dopamine agonists. Cabergoline is teratogenic, therefore contraindicated in pregnant ladies. So what you should give in pregnancy? Bromocryptine. Okay. So this is the treatment. What's along with this? If it is macroadenoma and it is compressing other structures in the brain, then you should go for surgery. Same like acromegaly, transsphenoidal resection of, that is transsphenoidal resection of pituitary gland. Okay. So sometimes along with these three features like infertility, secondary amenorrhea and galactorrhea, you also will have plus or minus visual symptoms. Why you are getting visual symptoms in pituitary adenoma? You know, right? This is the optic tract. This is the optic tract. So here itself you will get this pituitary gland. Okay, pituitary gland. Okay, so whenever there is enlargement of this pituitary gland, there is compression of optic chiasma. Most probably there is compression of inferior fibers of inferior fibers. So in optic chiasma, what you will have? Nasal fibers. So what happens in the field, visual field? Temporal fields are affected. Bilateral temporal fields are affected. So patient may present with bilateral, bitemporal, hemianopia or quadrantanopia if only inferior fibers are affected. Quadrantanopia. How you will see hemianopia? Yes, this is the visual field and this is nasal field and this is the temporal field. If it is happening like this, then it is bilateral hemianopia. Otherwise, if it is like this, as inferior nasal fibers are affecting, so superior quadrants are affected, that too only temporal region. Okay, so this is bilateral bitemporal quadrantanopia. So you got right. So if these visual symptoms are getting, then you should go for surgery. Must and should do surgery because these visual symptoms are very dangerous. If in future he will lose his eyesight also, that's why. Okay, so with this we are going to complete this prolactinoma. This is Dr. Nikita signing off. Bye.